Marcelo, thanks very much. It's certainly humbling to be part of a panel like this, including uh, some very prestigious interventionalists. So thanks for having me talk about this. It depends if you're disappointed about me not talking about visceral aneurysms because you would have been entertaining to see a vascular surgeon flop around like a fish out of water about an elegant topic like that. My apologies. On the other hand, the other member of the course committee who asked me to deal with this topic in general, I'm very grateful because this is a lot less painful for me to talk about, although they're both interesting. Regrettably, I have no disclosures to disclose for you. I will say that this, along with a number of these topics, you wind up getting into some off-label discussions, and obviously they're here, and I can address any of those with you if you'd like. Welcome to sunny South Carolina. If you're not from around here, this is actually not South Carolina. This is my house at my previous institution, but it was the quickest picture of snow I could come up with for this. A couple of things to keep in mind when you're talking about that. The point of that, if you hadn't been watching the news, was the snow here this weekend, but it wasn't quite that bad, but it was close. Couple of things to keep in mind with internal iliac or therapeutic internal iliac occlusion during endovascular aneurysm repair. Pretty basic points. To a lot of people in the room here, this is going to be bringing Coles to Newcastle, so I'm going to talk about it quickly and then talk about some things, some physiologic stuff that the surgical approaches would teach us, even though the reality is at the moment we're mostly doing this interventionally, for most of us at least. Obviously, whenever possible, you want to retain one internal iliac. If you're going to go off of that guideline, probably you want to do that in as staged a fashion as possible. Or look at some of the alternatives I'll talk about later. Obviously, coil versus plug embolization, the points underlying this have been really discussed during this panel already today. Coils have a lot more potential for non-target embolization, and that last coil taking you down. But the plug is more expensive for one, but has the potential to be a cost savings overall, and certainly potentially quicker. Optimal technique, a couple of quick points about that, just to be as proximal as possible in the internal iliac in order to try to maintain collaterals between the anterior and posterior division. I personally find that the best side for access is always the side other than the one I chose. It really is can go back and forth, which every time I try IPSI or contra because it just and you just have to go with the flow and don't be afraid to stick the other side and try to change your technique midstream if you need to. Some are very easy, some are a pain in the neck. Warn the patients about buttock claudication, warn them about the theoretical disaster of pelvic ischemia, meaning pelvic ischemia broadly, although a lot of these complications are lumped together under pelvic ischemia, but profound diffuse pelvic ischemia is a catastrophe. Surgical alternatives are worth talking about just from the standpoint of keeping the patients informed, and I'll go through a couple of those quickly here. Endovascular alternatives are something to keep in mind. They were probably more important before the plugs, but they're sometimes worth keeping in mind. And outcomes, obviously, we'll talk about a little bit too. Just background on AAA. That's a AAA for people like me who, when we see them open now, don't recognize that as a AAA because that is not an open AAA case for us now. An open AAA case for us now has to more clearly involve the renals and has to go much further into the pelvis and have a lot of associated occlusive disease. So approximately 15,000 people a year die from AAA, the 16th leading cause of death in the United States. That can be as high as 13th depending on how you run the numbers. Affects 2.7 million people, and lots of them are undiagnosed. These are always funny to me because they're from the SVS website. They're the patient educational stuff. But I think the patient on the right needs an EVAR and the patient on the left needs an open repair. So I always like to point that out. There's a huge landing zone at the top on the right. We'll hope the SVS was really thinking this through, and that patient on the right is just a really great open candidate, and he's 50 years old. And the person on the left, well, what they really did was extend their proximal landing zone and find a way to snorkel that or fenestrate it. So concomitant iliac aneurysm disease, it's present in 45% of patients. There's a little bit of a disconnect when Ricotta and colleagues at Mayo looked at internal iliac embolization. They found that they reviewed the literature, and in a little over 11,000 patients, they found that about 1,300 of those, or 11%, required therapeutic iliac embolization in order to achieve their EVAR. So this may be a difference in perspective from surgical to purely surgical to endovascular. surgical perspective, what you would call an aneurysm and repair or plug in distal to and ligate surgically is, with some of the new distal extensions, a good place to land in a subset of patients. So there's certainly a disconnect there. They may be difficult to treat by EVAR techniques unless you're willing to extend to some of the techniques that I'll just go through quickly here. And bilateral internal iliac, I'll say management here better than bilateral internal embolization, maybe need to be considered in very low aneurysms or aneurysms with a significant bilateral iliac component. Buttock claudication, colon ischemia, and the other things we've mentioned, and we'll talk about again. Just quickly, a couple of the surgical approaches to these. The key being here, this would be the ideal if you're going to do the whole thing within the abdomen, is to do your distal anastomosis to keep at least one internal iliac on either side. Actually, they've given this, it's the first time I noticed this, actually, they gave this patient 2 internal iliacs on the left, which is a little odd. But that would be my luck to find that on call one weekend. So on the left, we're just plugging in the left, and just a number of different ways to plug these anastomoses in, to external bilaterally and a jump graft to one of the internals. Likewise, direct revascularization of the left internal here, the external here, and a jump graft to the external. And the external again here, and the reimplanting the external as a transposition here with antegrade perfusion. I mention this only just because it kind of rams home a point that Dr. Rilling, when I was training in Milwaukee, and also Dr. Rilling and I would both know Dr. Town, but this is certainly one of those board points for any trainees in the area or anybody who works with trainees, is to I think in the hotel room you always want to maintain one internal iliac, whether you're doing your IR boards or whether you're doing your vascular surgery boards. Don't let anybody, without almost putting a gun to your head, force you to take both of these, except of somebody who's either quite palliative or quite an extremist. One example of something that I've never put this particular configuration in somebody, but as a theoretical option, if the IMA is patent, in order to try to maintain some antegrade perfusion to the pelvis, is to reimplant the IMA if you have to ligate both internal iliacs. So again, for the potentially interventionally and anatomically challenged in the room, just quickly, common iliac, the main branch of the internal, and then anterior and posterior division with all the different variables. Obviously a little more important to some of the things like Dr. Nemchuk was just talking about, but goal being to stay up in the main trunk of the internal iliac when you're doing these interventions. Just quickly, an example of one from ipsilateral access with a reverse curved catheter, some coils, thrombus beginning to set up, and an early therapeutic occlusion.